All right, let's do this. We are getting into arrhythmias part two. Part two. We talked about arrhythmias part one, a little bit review during class, and here is part two. Got my note sheet with me. Make sure I follow along, and you as well. Let's get into it. All right, so Wolf Parkinson's White. I can't pronounce things, I guess, today. Wolf Parkinson White is a type of arrhythmia that it just kind of like it doesn't hit the AV node right away, so it kind of bypasses. And instead of going to the bundle of His, it goes through something called the bundle of Kent. And I know you're like, what the heck does that even mean, right? Okay, so no, the bundle of His is normally right at the top of the septum here. The bundle of Kent's on the other side. And because it does this, it causes like this slurring to happen on the EKG with the QRS. Okay. There People don't normally know they have this until they start having symptoms like some fast heart rates, like SVT. They might have passed out. They might get a little chest pain when the heart rate gets up really high. So it just kind of it activates those ventricles a little bit early and can cause it to go fast. So treatments, we've talked about vagal maneuvers and beta blockers, cardioversion, and cardiac ablation. So the only thing I think I haven't talked about is the cardiac ablation. So that is when your heart rate does not want to slow down ever. We've done several cardioversions. We're taking beta blockers. They're not working. It's not allowing your heart rate to stay down like it's supposed to. They will actually go in and cauterize. So ablation means to burn an area of the heart tissue muscle to kind of create a pathway that makes the electrical conduction go in the right direction. So it's not constantly going fast. Okay. So it's an actual way they go in and literally burn the area of the heart that they need. And it kind of creates a pathway that the electrical conduction has to go through because it can't go through the burnt one. So it goes through the other one. So anyway, this is what the phenomenon looks like. So it's this called a delta wave. It can look kind of like a bump or a slur where it just kind of keeps going up. And this is actually a really good picture of one. This one kind of looks like the bump here, and this one looks like a slur. So you'll see the P wave is literally touching the QRS. So the P to R interval is going to be very, very short. Obviously, if it's touching the QRS, and our P to R interval is really P to Q, remember? Yeah, I know the one that doesn't make sense to me either. It's really P to Q, so it's really small. This one's only just a few tiny boxes wide. So that's one indication is the P to R interval is going to be super short, and it's super short because of the delta wave. You'll see this phenomenon, this slurring, how the P wave and the QRS touch basically, and it slurs up into the QRS. It looks a little bit different in each one, but you can definitely tell that P wave is next to the QRS. So you have the same picture on your paper. I would circle the delta wave and just kind of mark that that's the delta wave. Mark down that those are shortened P to R intervals as well. Okay. All right. So let's get into junctional rhythms. So junctional rhythms don't start in the SA node. They start near the AV node. So the AV node, that area where the AV node, between the AV node and the bundle of His is called your junction. So if it's a junctional rhythm, it's starting somewhere in that area, somewhere between the AV node and the bundle of His. Okay, sometimes it's starting exactly at the AV node, sometimes it's starting at the bundle of His, just depends. Okay, so we're going to go through each one of these different types of junctional rhythms. And then we'll talk about a premature junctional complex or contraction, a PJC as well. That is not a rhythm, this is just an early beat. We did mention those briefly in the last lesson. We'll get into them more deeply today. All right, so a junctional rhythm, again, it originates in the AV junction. Okay, so the AV junction, like I said, is somewhere between the AV node and the bundle of His. So it's not starting in the SA node. Since it doesn't start in the SA node, the P wave is going to be different because the SA node is what causes the P wave. So let me say that again. Since the SA node causes the P wave, a normal looking P wave would come from an SA node. Since it's not starting there, the P wave is going to be different. So the P wave is going to be what they call absent or inverted before or after the QRS. You're like, wait a second, that makes no sense at all. I'll show you some examples. So the P wave will be absent, meaning there's no P wave at all. Occasionally there's no P wave at all. It ends up being buried somewhere in the QRS, so you can't see it, okay? And sometimes it comes inverted. So an upside down P wave right here, upside down P wave, inverted P. And it can come before the QRS and it can actually come after the QRS. It looks very strange when it does that. But so it's somewhere in there in the ventricles squeezing. It's a little out of sync. The QRS complex is typically a little bit wider than normal, especially if the P wave is happening inside the QRS, but not always. It's sometimes wider than normal. The heart rate is going to be between 40 and 60 beats per minute for a junctional rhythm. And I want you to think about that for a second. Remember that our SA node beats 60 to 100 beats per minute? All right, how fast does our AV node beat? 40 to 60. So if it's coming near the AV node, it's going to be beating at 40 to 60 beats per minute. So right away, we hook someone up to the EKG machine and they have a heart rate of 44. Right away, we're like, this may not be, we know it's not NSR, right? So it's going to prompt us to look a little further. And then we notice that the P waves are either absent or inverted. That tells us right away that this is a junctional rhythm. Okay, so the rhythm going to be regular. It's just going to look a little different than the other ones. So here's a good example of an inverted P. This one down here has no P wave. I think I have a little bar collapse. Thank you. No, didn't want to collapse. Okay, whatever. Can I move this bar? I can. Fantastic. All right, so this has a no P wave and this has an inverted P wave. These tell me right away that these are some sort of junctional rhythm. And a regular junctional rhythm has a heartbeat between 40 and 60 beats per minute because it's coming from around the AV node, which beats 40 to 60 beats per minute. Okay. All right, so here's some good variations here. You can see some different variations. If you want to circle them, circle these on your paper. So this is what an inverted P wave looks like in front of the QRS. This is what one looks like buried inside the QRS, so it would be considered absent. If there isn't a P wave there, it's absent, and it's just buried somewhere inside this QRS. And then there's an inverted P wave after the QRS. I know it looks a little bit like ST depression. It looks a little bit like a J wave. It looks a little bit like a lot of other things, right? Like in the last one, you guys were all confused. This is different. It is different. This does look like a J-wave Osborne wave, but it's well below the isoelectric line, and this would be above. J-waves are typically only seen in ST elevation of some sorts, like early repole. So if this is below the isoelectric line, and then we have an inverted something right next to it, this is definitely an inverted P wave after the QRS. We'll look at a few more examples as we go. You'll hopefully start to see the difference in what it looks like. All right, so let's get into junctional brady. So bradycardic, as we know, is slow. If it's a junctional rhythm, it's coming from somewhere from the junction, right? So originate in the AV junction, somewhere between the AV node and the bundle of His. It is the exact same characteristics as a junctional rhythm, meaning the P wave is going to be absent or inverted before or after the QRS. So P wave, again, will be absent or inverted before or after the QRS. That's one indication that this is some sort of junctional rhythm. The QRS may be a little bit wider than others. It may or may not be. But then we have a heart rate that's less than 40 beats per minute. So in what instance, I'm asking why. So in what instance would our heart rate be below 40? Where is this starting from? Think about that for a second. I know you know this. The rhythm will be regular. Okay, so remember that any junctional rhythm, the junction itself, the junction is somewhere between the AV node and the bundle of His. So AV node beats 40 to 60 beats per minute. How fast does the bundle beat? 20 to 40, yes. So if it's below 40, it's most likely coming from the bundle of His. Okay, so that would be why it's less than 40. Now we know heart rate less than 40 is not functioning, right? This is just sustaining life until we can get intervention done. So it's not good. So you can see down here, this is definitely an inverted P in front of it. Look how slow this is. Even if I did the countdown, 300, 150, 175, 60, 50, 40, who knows, right? I'd have to count all these. 5, 10, 15, 20, 25, 30, 35, 40, 45, 46, maybe 46, 47. So let's do that math real quick. 1500 divided by 46 gives me a heart rate of 32. We got a problem, Houston. Yeah. So this is like the little mums that come into the emergency department and they're like, I don't know, I just been feeling really tired and winded, and I don't know, I just don't feel myself, a little lightheaded every time I get up. And she lays on the bed, I hook her up to the EKG machine, and her heart rate's 32. I'm like, well, I can probably guess why. But I notice when her heart rate is 32, if there's a P wave or not, or if it's inverted or absent, we notice right away. And then we can tell that this is now the SA node has failed, the AV node has failed, and now the bundle of His has taken over. We got a real problem here. This person will most likely need a pacemaker if that happens that way. All right. So we have the regular junctional rhythm, which is 40 to 60 beats per minute. We have a junctional Brady, which is going to be our below 40. That's a scary one, right? We have something called accelerated junction. Now, we have not used this term before for a faster rhythm or normally use tachycardia, and there is a junctional tach. So this one also originates in the AV junction. It's going to have the same attributes as far as the P wave goes. The P wave will be absent or inverted before or after the QRS, so same characteristics. QRS may typically be wider than normal. Now the heart rate is going to be 60 to 100 beats per minute. So this masks itself as NSR. When we take someone's heart rate, either with a pulse ox or their radial pulse, their carotid pulse, whatever, and their heart rate's 72, we don't think anything of this. We would not be able to tell that this was an accelerated junction rhythm until we hooked up to the EKG. So you'll see that the heart rate is normal, 300, 150, 175. This is about 80 beats per minute. But notice that there is no P wave. The P wave is absent. So the only indication that this is some sort of junctional rhythm is the fact that we did an EKG and saw that the P wave is absent. Okay, so because it looks and sounds like NSR, if the heart rate's in the 80s or 70s, right away we think this is NSR. Then we hook them up and see that there's no P wave. So this is called accelerated junction. So regular junctional rhythm is the AV node working, 40 to 60 beats per minute. Junctional Brady, below 40, that's the bundle of Hess working. Accelerated junction, it's still the AV node, but it's compensated. It knows it needs to go faster. So the SA node hasn't been working for a while. So it's like compensated and picked up its pace. Okay. Last one of the junctionals is junctional tach. So just like the definition of tachycardia says, this is a heart rate over 100. So it's exactly the same as other junctional rhythms where the P wave will be absent or inverted before or after the QRS. Sound like a broken record. All of the junction rhythms look the same. The only difference is the heart rate. Okay. QRS may typically be a little wider, and then the heart rate will be above 100. That is the definition of tachycardia, heart rate above 100, right? Yeah. And then the rhythm will be regular. So this is actually a really good example of a junctional tach down here, this EKG itself. We know the heart rate's going a little bit faster than a normal one. So let's see, 300, 150, it's a little over 100, maybe 110, 115. I could do the 1500 method if I want to, but I just did the countdown just to make it quick. But look at the P wave. Can you find the P wave? You have this exact picture on your paper as well. Circle the P waves. They are inverted right here. That's an inverted P wave. This is an inverted P wave. And this is an inverted P wave. So they are inverted and the heart rate is over 100. So this is a junctional tachycardia. Okay, so in case you didn't catch on, all the junctional rhythms are the same. Well, they have the same characteristics. The P wave will be absent or inverted before or after the QRS. And then you just clarify or categorize which junctional rhythm it is by the heart rate. Regular junctional is 40 to 60 because that's the AV node. Junctional Brady is the bundle of His, it's below 40. Accelerated junction, that's a new term, is 60 to 100, and junctional tach is above 100. Okay, let's keep moving. So then we have these, here's a couple of examples more of junctional rhythms. So an accelerated junction is going to be, notice there's no P wave here. We could count little boxes if we wanted to, but this is a normal, like normally to 60 to 80 beats, 60 to 100 beats per minute. Junctional tach here, this is the P wave after the QRS complex. Inverted after, and it's tachy, so it's over 100, 300, 150, 100, it's like 130. So this is a tachy junctional because of the P wave that's inverted after. Accelerated junction, this is a normal like 60 to 100 beats per minute with the P wave in front is absent. Okay, so let's talk about PJC. PJC, premature junctional complex. It's similar to the PAC, which is that early atrial contraction, right? This is something that's typically benign. It's, again, not a big deal. It's just a beat that comes a little bit early. If you have 4 or more in a row, it becomes junctional tach. I don't typically see 4 or more in a row. It's not considered, not a common thing. But it looks almost exactly the same on an EKG. So as the QRS complex. So it looks like a PAC originally or initially, and then you look for the P wave. So that P wave is going to tell us exactly if this is a PAC or if it's a PJC. So notice down here we've got some regular rhythms, and then we have an early beat. Regular rhythm, and then we have an early beat. There's typically what's called a compensatory pause after that early beat. So this does not reset the SA node. It's not happening from the SA node. The junction, it's coming from the junction, the AV junction. We know it's coming from the AV junction because that P wave is going to look either absent or inverted. So here's my first early beat, and the P wave is right here. It's teeny tiny, but it is upside down. And you have the same picture on your paper. You might be able to see it on your paper a little bit better. So this is the QRS with the P wave inverted. And then we see a little bit of a pause after. This is that compensatory pause. We go back into a regular rhythm, and then another early beat comes. Here's an early beat. We know it's early because it comes a lot sooner and it's closer. So I'm going to tell if it's a PA or PJC by the P wave. The P wave is, again, you can probably see this better on your paper, is there, but it's inverted. So if it's upside down inverted, it is a junctional. So it's PJC, and then we see this compensatory pause after. Okay, hopefully you got that. Take a look at your paper. I have another picture, I think, on the next page. Oops, let me go back one. Yeah, so here's some more pictures of PJCs. And you have this picture right here at the bottom of your paper. Notice we have regular PQRSTs. Follow the rhythm. Follow the rhythm. Oh, wait, there's no P wave here, and there's a pause. This is a little wider than normal. Here's our PJC, and we know it's a PJC because it came a little bit early, number 1, so that makes it premature. J means junction, so it's got to have that either P wave that's absent or inverted before or after the QRS. It is absent. There is no P wave here. And then there'll be that compensatory pause after. So this has all the markings of the definition of a PJC. If we look down here, again, we got PQRST, follow the rhythm, PQRST. Look for a regular rhythm. Oh, this one came a little bit early. See how it's early? I look for the P wave. There it is. That P wave is actually inverted. It does not look like that, right? It's ectopic. Remember the ectopic term that we used last lesson? Ectopic means it's not coming from the SA node. So it's ectopic, so it is, and it is inverted. So we know it's coming from the junction, and then we see that compensatory pause. So there's a longer pause after this one. Hopefully you got that. If not, rewind it, redo it. And there's something called a junctional escape beat. So this we saw The PJCs came early. This comes actually late. So it originates in the AV junction, but it comes after the compensatory pause. So remember that pause we saw after the PJC? Now we're going to see it before. So the P wave again will be absent or inverted. The P to R will be normal. The QRS will be narrow. It's going to come late. So I'm not sure if I have it circled on here or not. Yes, I did. Okay, so this right here is a junctional escape beat. So a PJC, a premature beat, comes early. An escape beat comes late. So what I mean by late is there'll be a pause before the beat happens. So if we take a look here, we have our regular PQRST, and then there's a pause. We're like, what's happening? We think maybe it's one of those sinus arrests, right? It's just a pause, and then we do have a beat. But notice this beat does not have a P wave. That tells us it's an adjunctional escape. So we started to have a pause. We started to have a maybe a sinus arrest, and the junction took over. Because it's like, wait a minute, the SA node didn't work. I better take over. So the AV node took over. So that's what a junctional escape is. And we know it's a junctional escape because it's got a pause before the different beat. And this different beat, different, means it does not have a P wave. PJC comes early. Junctional escape comes late. Okay. Let's see. Here's a couple of junctional escapes here. I don't know what happened. Hold on, let me get out of there. Something clicked weird. And I need to restart. I don't know. Can't be perfect every single time. All right, here we go. So junctional escape beats. Here's a couple more options or not options, examples. So we have these long pauses and then a beat comes after. And we go back to a regular PQRST and then a pause and a beat after without the P wave. That's a junctional escape. Down here you can see the same thing. I guess my little guy's in the way again. Move it. So you can see we have some regular beats going on, and then there's a pause and no P wave when the first beat comes out. So it starts to beat. That's a form of sinus arrest where the sinus SA node stops working. And because it didn't work, the AV node's like, I better jump in. That's what the backup system's for. So it jumps back in, and this is a junctional escape. Okay. Let's get into the ventricular rhythms. We finished all the atrial rhythms. If you need to take a break right now, you certainly can. I'm going to keep rocking and rolling, but you can take a break right here. It's a good spot to stop. Okay, so premature ventricular contractions, PVCs, are ventricular depolarizations that come early. So premature. That's what P stands for, premature. And the V stands for ventricular. So this means that the ventricle depolarizes before the SA node can fire. Yeah, it came way too early. I wanted to take a turn to go first. So it presents itself as an early or premature, like with a compensatory pause after, and then the P waves won't be there, obviously, because the SA node didn't fire. But what's weird is this QRS is going to be big, weird, wide looking, like out of place. It doesn't look like it belongs there. Okay, it looks very different from the other QRS complexes. So this is what these PVCs are circled down here. You can see our regular PQRSTs going on, and then all of a sudden this early beat comes and it looks big, weird. It's tall, it's wide. It doesn't look like anything else we've seen. This is a PVC. So it's your ventricles deciding that they want to go first. And it comes early in the cardiac cycle. So it's depolarizing before the SA node has a chance to fire. It creates this weird looking phenomenon on your EKG. These come in patterns too. Pretty interestingly, comes in patterns. So we have what's called unifocal and we have what's called multifocal. So I'm sure you know, uni means one and multi means many. So if we have a couple of different PVCs in that lead that show up, this one here, and we have some frequent ones happening, and they are the same size and shape in that specific lead, that's considered unifocal. And down here, you can see here's a PVC right here, and there's a PVC right here. Notice how they stand out like a sore thumb. They're like, I don't belong here. I'm not the same size and shape as anything else on this paper. I am like, it's like, hey, here I am. I want to stand out. There's usually a pause after. So that's what unifocal looks like. So multifocal would be in the same lead. So say this was lead 2. And I see a PVC here, and then down the line, I see another PVC, and they're shaped differently. Then that's called multifocal. So all that is the shape and size of the PVC. When we refer to unifocal and multifocal, it's just the size and shape. Now you might see different sizes and shapes in different leads. So like lead 2 might have a PVC that looks like this, and lead 3 might have a PVC that looks like this. As long as they all look the same in that lead, that's unifocal. I almost said unicycle. That's something you ride. My brain's toast today. Okay, so that's multifocal. All right, so again, just some more pictures. This is a multifocal, so this would be the same lead. Say this was lead 2. I see one PVC here with a pause, regular, and then another PVC with a pause. They are not the same size and shape, so this is a multifocal. This picture is just pointing out that don't forget that there is a pause after that. That's called a compensatory pause. It's allowing the SA node to kind of catch up, if you will. Let's go through the different types of PVCs. All right, so these are, just follow what I have on the page here. You will have to write these down. So you might need to pause this once I'm done talking to finish all these definitions. An infrequent PVC is less than 5 PVCs per minute. Okay, so you have them hooked up to an EKG machine. You know we're going to take a 10-second EKG, but we're hooked up for a few minutes before we actually get it to settle in and it looks well, it looks good. If you see less than 5 in that time frame, less than a minute, then it's considered infrequent PVCs. Now, frequent PVCs, this is what I have typically, 5 or more PVCs per minute. Okay. I don't have them all day, every day, but there's certain times of day that I definitely have more frequent ones than infrequent. If you have just one random PVC that shows up out of nowhere, which is very common, it's benign, nobody really cares about, that's considered an isolated PVC. It just comes once by itself. So when we have group beats, these are going to be group PVCs that come in groups or patterns of 2 or more. So let's go through some of those patterns. Okay. So the first one is called a couplet. It's 2 PVCs in a row. I'm circling your PVCs in a row here. This is a couplet. Notice we had a regular QRST and then a PVC, and a pause. There's our compensatory pause. This is called a couplet. So if you think of a cute little couple, there's 2, right? That's called a couplet. Now, this is ventricular attack or VTAC is 3 or more PVCs in a row. This is incorrect. This should say 4. I took this off the internet, so I didn't change it. This should say 4 or more PVCs in a row is considered VTAC. So here's 4 in a row. 1, 2, 3, 4. This is considered VTAC. Now we're going to learn about VTAC later, but this is a bad rhythm. This leads to, if it's not treated, can lead to death. So it's a really bad rhythm. It's fast. It's the ventricles just doing whatever they want. They've taken over at this point. Your atria can't depolarize. So you're not really pumping blood very well. So something called bigeminy is when a PVC comes in a pattern where it comes every other beat. So we have a regular PQRST and a PVC pause. Regular PQRST, PVC pause. Regular PQRST, PVC pause. See how it's coming every other beat? We have a regular beat, PVC. Regular beat, PVC. Regular beat, PVC. This is called bigeminy. Bi, of course, is 2. Bigeminy. Bigeminy, I think you've got it. Yeah. Then there is trigeminy and quadrigeminy. So this is an example of trigeminy where the PVC comes every third beat. We have a regular PVC. regular PVC. This is a trigeminy. So it's quadrigeminy would be every fourth beat would be a PVC. Okay, so they can come in patterns like that. And we just name them what they're called, like trigeminy, bigeminy, quadrigeminy. Yeah. And then don't worry about that bottom. It says the R on T phenomenon. We're not going to talk about that. You don't need to know that. So if you have not filled all these out, don't forget that VTAC is actually 4 or more PVC in a row, not 3. It's 4. So write that correctly on your paper. Once you have all this completed, you can switch. I'm going to switch to the next page here in a moment. But if you need to finish, just pause me right now so you can finish writing what you need to write. We're going to go through some more examples. All right, so here's some examples of couplets. So you have this picture or one of these pictures on your paper. And again, we have a regular PQRST happening here. And then all of a sudden, 2 PVCs. They're big and wide. They don't look normal. They came a little bit early with a pause after, and there's 2 stuck together. So this is a couplet. Again, they stand out like a sore thumb. It's very easy to point out the PVCs. They don't look normal. Down here as well, regular PQRST, and then we have 2 PVCs together. That's a couplet. So go ahead and circle those on your paper and name them couplets. Let's take a look what a triplet is. So a triplet, like 3 little babies, right? 3 little triplets. We have 3, 1, 2, 3 PVCs all in a row with a pause after it. So this is not VTAC yet. If there was a 4th one, it would be VTAC. So 3 in a row is considered a triplet. 1, 2, 3, compensatory pause. 1, 2, 3, compensatory pause. And we know these are PVCs because they're very different than the regular rhythm that's happening. PQRST, PQRST, and then these big wide complexes. All right, so bigeminy is that every other beat, right? So every other beat is a PVC. Regular QRST, PVC. Regular QRST, PVC. Bigeminy. Every other beat. And here's another bigeminy. Every other beat is a PVC. Regular PVC pause. Regular PVC pause. You'll see that compensatory pause. Okay, so trigeminy is going to be every third beat. So every third QRS complex is a PVC. So this is, again, you should be able to see the pattern. Regular PVC, regular PVC, regular PVC. The PVCs don't look normal. They look big and wide, tall, wide, alien-like. They don't belong. Okay, that's a trigeminy. All right. So you have this chart on your paper. I'm going to help you fill in. Some of this information is on this slide here that will help you fill in the chart. I don't think I have a chart on mine. No. Okay. So the PAC, A stands for atrial. So in that first box where it says PAC, A equals, you're going to write atrial. A stands for atrial. The P wave is going to be upright. You can write normal if you want to in front of the QRS. The QRS complex is going to be normal. We're doing all PAC right now on your chart. Does it reset the SA node? Heck yes, it does. It's the only one that resets the SA node because it starts in the SA node. The PAC, atrial, starts in the SA node. Is there a compensatory pause with this? No, there is not. There is no compensatory pause with a PAC. It resets the SA node. Moving down to PJC, and again, this is your second line in your chart on your paper. I'm looking at the chart right here, by the way. This chart right here. So on the chart on your paper, the PJC, J, stands for junctional, which is the AV node. So in that first box, J equals, you're going to put junctional. You can put AV node. It comes from that junctional area of the heart between the AV node and the bundle of His. Is there a P wave for this? Yes, but it's going to be absent or inverted. So make sure you write down absent or inverted. The QRS complex will be, it's maybe a little bit wider. It's not always. Maybe a little bit wider. Does it reset the SA node? No, it does not. It does not start in the SA node, so it does not reset the SA node. There is, however, a compensatory pause. So a junctional rhythm has a compensatory pause. That would be yes in that one. The last one is a PVC. So in that last box, V equals ventricle. So it's starting in the ventricles. This is the ventricles deciding they want to go first. They're depolarizing before the atria have a chance to. Okay, not always the smartest thing. One or two now and then, no big deal. We start getting them all coming in a row, we got a problem. So is there a P wave for this? No, there's absolutely no P wave. And that is because it's not starting in the SA node anywhere near it or the junction. It's starting in the ventricles. Is there a QRS complex? Yes, it's big, wide, and weird, bizarre looking. Okay. Does it reset the SA node? No, it does not start in the SA node, so it can't reset it. So it's a no. There is definitely a compensatory pause. So hope you got that right. I'll go through them really quickly again to make sure you have them all down. PAC, A stands for atrial. There is a regular P wave, normal P wave. QRS is normal. It does reset the SA node, the PAC. There is no compensatory pause for PAC. For PJC, J stands for junctional. The P wave is absent or inverted. The QRS complex is maybe a little bit wider, not always. Does not reset the SA node. There is a compensatory pause. For PVC, starts in the ventricle. There's no P wave. It doesn't start near the SA node, so there's no P wave. The QRS complex is wide and bizarre looking. It does not reset the SA node, and there is a compensatory pause. So this chart should help you when you're doing some sort of assignments and stuff, what those mean, and just kind of give you an idea while you're trying to figure out which type of premature complex it is. I'm going to skip over this. This is skipping it. Well, this is kind of, yeah, maybe I'm not. All right, I lied. So the SA node does reset the PAC does reset the SA node. It does no compensatory pause. PVC does not reset the SA node. It does have a compensatory pause. You can kind of see here, PVC compensatory pause. The PJC does not reset the SA node either, and there is a compensatory pause after. Okay, just kind of give you an examples. All right, so a ventricular escape, same as a junctional escape. So remember, escapes come late. Escape is late. Premature is early. So it can also be called an idioventricular rhythm. It does originate in the ventricle, so it's going to be big and wide. Anything big and wide and weird looking is from the originating in the ventricle. The QRS is going to be big and wide, like I said. The P wave will be absent because it's nowhere near the SA node is starting this. This is ventricle. The QRS is greater than 0.12. It's going to be big and wide. The V rate is going to be 20 to 40 beats per minute. Again, remember 20 to 40 beats per minute, right? That is the bundle of His. Now notice the bundle of His is right at the top of the ventricles. So it's coming below the bundle. It's starting in the ventricles. It's going to be low, 20 to 40 beats per minute. You can see the ventricular escape down here where we see the pause before this big Y complex, and this went into a rhythm. Now you can have just one escape beat, but if it starts with a regular rhythm and then goes into this one, slow, big, wide ones, then it's a ventricular escape rhythm. All right, so if we take a look at this one, look for the ventricular escape, see if you can find it. And where's the compensatory pause for that one? Okay, so you can see the pause here, right? And then we look for the PVC, the big, wide, weird-looking one. It happens to be right here. It was not before the pause, it was after the pause. That makes it a ventricular escape. If this was over here and the pause was after it, it would be a PVC, but this is a ventricular escape because the pause is before it. Hopefully that makes sense. Oh, I circled it for you. And there's the pause. Just overkill here, right? All right, so VTach. This is bad. All right, VTach is a rhythm that originates in the ventricles. It stands for ventricular tachycardia. It has a heart rate greater than 120. The QRS complex is going to be super wide. Okay, the rhythm will be regular. And there are two different types of VTach. We have something called polymorphic and monomorphic. The two types have the same attributes, meaning they have the same fast heartbeat, wide complexes, just that they look a little bit different. Okay. Treatments for this, if any fast heart rate we have, those vagal maneuvers come in handy. A cardioversion. Sometimes we have to do CPR on this person. It's not always a shockable rhythm. And then long term, once we get them fixed up and they came out of this rhythm, beta blockers, ablations, pacemaker defibrillators may be in order. So this is what polymorphic VTach looks like. So polymorphic, poly meaning many, morphic meaning morphologies. So this has many morphologies of basically the PVCs. They're all different sizes and shapes. They may not come consistently. They may come at different times and try to come regular rhythm in between. So right here, this is a very polymorphic VTach. So all of these PVCs are big and wide, but they're not all the same size and shape. Notice they're not all the same size and shape in those leads. And then we actually try to go back to regular rhythm, then we start back into VTach. So this is considered polymorphic. Poly meaning many, lots of different morphologies in the PVC shape and size. And they may come in and out of it as well. Monomorphic looks different. So mono meaning one. Monomorphic means that all the PVCs are all the same size and shape in that specific lead. This is also considered sustained VTach. This is bad. I see someone like this and we need to get them back immediately. Heart rate number one is super, super fast. And the ventricles have taken over. The SA node can't depolarize like it needs to. We're not moving blood the way we should. This person usually looks gray, sweaty diaphoretic, but not the good sweaty. Obviously, the I'm sick sweaty, grayish to yellowish color. They are disoriented, typically lightheaded. They may even be unconscious. Okay, so this is a critical EKG. There is a type of polymorphic called torsatus. It just means torsatus de pontis. It just means twisting about the points. And if you take a look here, it does kind of look like you took a ribbon and twisted it, right? We have some wider places and skinny, but it comes in that pattern where it gets wide, skinny, wide, skinny, wide, skinny. This is what torsatus looks like on your paper. So it is sustained, but it comes in a pattern where it gets wider and skinnier. Looks like it's twisting, like a ribbon and twisting. That's torsatus. If we have VTach and then when it's not treated, we end up with VFib. This is bad. Okay, so VFib makes no sense at all. We had atrial fibrillation before. This is ventricular fibrillation, where the ventricles are literally just quivering. They are not squeezing and pumping. They're just quivering. Okay. There's no specific pattern happening. There's no P waves, no QRS. The V rate is greater than 300. So you can see all these wiggles here are the ventricles just going like this. There's no squeezing or pumping happening. This person's unconscious. You need to do CPR and defibrillate. Okay. It is a shockable rhythm. You can shock this person. But you need to do CPR right away. You're not going to, if you feel a pulse, you're not going to be able to feel it. It's going to be very, very weak. Long term, once they come back from this, so that they don't go back into VFib, after VFib is death. Okay, so VTach, VFib, death. See why VTach is bad? Your body can't sustain VTach for very long before it turns to VFib. So long term, if we get them back, they've recovered, now they're awake, they're alive, all those things, they'll be on beta blockers, pacemaker defibrillator will be installed to make sure this doesn't happen again. Their own personal defibrillator in their body. Bad rhythm, critical. And they are unconscious. All right, so a ventricular standstill just means lethal. This is lethal. There is no pulse. You will not feel a pulse for this one. The SA node tries to fire everything, but it's not making it anywhere. There's no atrial depolarization happening. The SA node fires, but nothing happens after that. So you can see SA node firing, but nothing happens. Okay. There's no ventricular depolarization. The P waves are present. There are P to P sometimes. You can count P to P, but there's no depolarization happening. No P to R intervals, QRS complexes. Treatment is, again, CPR and defibrillation. So you won't feel a pulse on this person. It is occasionally shockable. You have to hook up the pads to the person first, and it will tell you if it's shockable rhythm or not. If it's shockable rhythm, it will tell you. Or the people at the emergency room have the ones that can bypass that. They can just shock no matter what. We are getting there. Let's take here's some ventricular standstills here. So we started to have a little bit what's called a heart block here. We'll learn that in the next lesson. And then all of a sudden we have P waves with no QRSs. P waves and no QRSs. P waves and no QRSs. Not good. Nothing's depolarizing. No blood is moving. Okay. So the ventricles have gone on strike, basically. They're standing still. That's what that means. You can circle them on your paper the same way I described them. There are P waves and no QRSs. And then after all of this, if we head to this one, this is now called asystole. Okay, people call this flatline. It's not called flatline in the medical field. We never say the person went flatline. We say they went asystolic. It is lethal. There is no pulse. This is not a shockable rhythm. You cannot shock them when they're in asystole. There's no P waves. If there's no electrical conduction to shock to get started again, then you can't do that. It's treated with CPR and epinephrine. We give them medication to restart the heartbeat. You can't shock them. It won't work. Okay, so once they've gone asystolic, it is lethal. This person is technically dead. At least they have no electrical conduction in their heart. Hopefully the medication will help them start up again. But it's not called flatline. It's called asystolic. And it looks just like a flat line, right? I know. It's not called that. I know you want to. It's not. It's asystolic. All right, so an agonal rhythm, so it's a variant of asystole, so it's nothing really is really happening. So if we've given them drugs to restart their heartbeat, we might get this a little electrical waveform that forms. It's kind of like a, hey, there's something happening in here, but I'm not really ready to start my heartbeat again. This is not doing anything to the heart. It's not moving blood. The QRS is way too wide to do any type of depolarization properly, so it's not pushing any blood or anything like that. They are severely bradycardic. If you end up with this, they're unconscious again, and this is same treatment as asystole. We're still doing CPR on this person, and we're still trying to give medications to get their heart rate to come back. Okay, just a form of asystole, basically. All right, let's practice just a little bit here. This is a review of some of the junctional rhythms. I'm going to check to see if I actually printed these out for you on your paper. I did not. Okay, so let's practice. If you want to pause and take a break for a minute, you can, and then do the practice. I'm going to keep rolling. So we're looking at this one. We're looking at the heart rate or the V rate. So we can see that 1, 2, 3, 4, 5. It's kind of slow, isn't it? 5 times 6 is only 30. So this heart rate is only 30 beats per minute. So right away, we know it's slow. This is not normal, right? So we're going to check for the P waves, see if they're absent or inverted before or after the QRS, because it might tell us it's a junctional rhythm. Junctional rhythms can be 30 beats per minute. So P wave, is there a P wave? I do not see a P wave here. Oh, wait, what's that? That looks like a P wave after. There's nothing here, a P wave after. This P wave is inverted after the QRS in some of them and absent in others. That's okay. That does happen sometimes. They both mean the same thing, right? So I do see a P wave absent or inverted after the QRS. So this is going to tell me it's some sort of junctional rhythm. Based on the heart rate of 30, the junctional rhythm category it falls into is junctional Brady. because junctional brady is below 40 beats per minute, and this was 30 beats per minute. And it's junctional because the P wave is absent or inverted. So this is a junctional brady one. All right, let's take a look at this one. So what's the heart rate for this one? We don't have a full strip, so we'll have to do the 1500 method. This is 5, 10, 15, 20, 1, 2, 3, maybe 4, 23, 24. Let's get the heart rate. The heart rate's about 65 beats per minute. So we'll put the heart rate as 65. Is there a P wave? Do you guys see the P wave? I do. It's not normal, is it? Here's the P wave right here. It is upside down. It's inverted. So a heart rate of 65 with an inverted P wave. So 65 does not fall into the regular junctional rhythm. Regular junctional rhythm is 40 to 60. 60 to 100 is not. This is the accelerated one, that new term we've used. So accelerated junction is that P wave is absent or inverted before or after the QRS. And the heart rate should be somewhere between 60 and 100. Since this is 65, this is an accelerated junctional rhythm. Okay. All right, tell me if it's a PJC, PAC, or PVC. Each one of those has a different type in them. PVCs jump out to me. They're really easy to point out. So see if you can find the PVC. It's in one of those. Starts in the ventricle, so it's going to be big and wide and bizarre looking. Here's our PVCs down here. And there are two different sizes and shapes in the same one. So this is actually a multifocal PVC strip. Okay, so the difference between PJ and PAC, the QRS-T is going to look normal. The difference is going to be the P wave. In a PAC, the P wave will be upright and normal looking. The PJC, it's going to be absent or inverted. So let's find the early beat here. Here's an early beat right here. Where's the P wave? Right there. It is upright position. It looks a little different than that one. It's a little ectopic, but it's upright. So this is a PAC. And again, it's a PAC because the QRS-T is normal. The P wave is upright. Down here, let's find the early beat. Normal, 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 normal. Early beat right here with a pause after it. Early beat. So let's look for the P wave. Since the QRS is normal, it's not a PVC. Look for the P wave. This P wave is right here. It's not upright, is it? It's inverted. So that inverted P wave in this early beat tells us it's a PJC, and the confirmation of that is that pause after PJC. Okay. All right, we grouped the PVCs together. See if you can find the PVCs and how they're grouped together or what pattern they came in. The first group, you can see PVCs every other beat. When it comes every other beat, that's considered bigeminy. Okay, bigeminy, I think you got it. Yeah. PVC every beat, other beat. Regular PVC pause, regular PVC pause, regular PVC pause. Okay, so this is a bigeminal pattern. Down here, we have all these regular PQRSTs, and then we have two PVCs together with a pause. Two stuck together. They're best friends. They are a couple, so they are a couplet. Down here, I see some couplets here, two couplets, but then in the center, there's 1, 2, 3 in a row. That becomes a triplet. So there's couplets and triplets down here. Hopefully you start to get this pattern. It's pretty easy, hopefully. Okay, so what's going on here? All of those QRS complexes are big and wide, right? Yeah, big and wide, and they are all the same size and shape in each of the leads. It looks like a fast heart rate, so we know it's some sort of tach. And if they're coming from the ventricle, because they're big and wide like PVCs, we know they're coming from the ventricle, then this is just ventricular tachycardia. Then you can actually narrow down what type of VTach it is. Either it's monomorphic, polymorphic, or torsadas. Mono meant one size and shape in each lead. Poly meant many sizes and shapes. Torsadas was like the ribbon. So this one, if you haven't guessed already, is monomorphic VTach. Oops. Ugh, this is bad. That's VFib. There's no other way to describe it. Just a bunch of wiggles. VFib, this is when the ventricles are just going ee. So there's a little bit of electrical conduction happening, but it's not really pushing any blood. It's just quivering, basically. Okay, this is lethal. They're unconscious, shockable rhythm. And then this one, of course, it's not flatline. It's not flatline. Asystolic, asystole, right? Yeah. All right, we are done. There is an Arrhythmias dance to watch. You are welcome to watch it without me. I'm going to close this movie off, though, this video, and I'm going to see you next class. So let me know if you have any questions, and have a good one.